Assalamu alaikum and good evening, dear physicians. Today we have our 19th lecture, which is ECG in children, normal and abnormal. It is going to be delivered by our Dr. Abdullah Al Jamil sir. Before going on to starting the lecture, I request Professor Wadud Chowdhury sir to say some words about our Dr. Abdullah Al Jamil sir. I request Professor Abdul Chowdhury sir to say some words. Wadud sir.
Assalamu alaikum and very good evening to everyone in here in the Asia. And I think it's good morning to Rafiq sir and Hafiz sir. Last lecture we have very good discussion about the normal pediatric ECG, its variation, what to expect, how to do it, and all those things. Today we'll be enjoying the next installment about the disease aspect that we can get from a pediatric ECG. And we are very fortunate that many eminent pediatric cardiologists are along with us, and that's a pleasure for us. And also today are getting two eminent cardiologists, Dr. Rafiq Ahmed and Professor Chowdhury Hafizullah with us. So we'll be enjoying their comments and insight along with the lecture that will be given by Dr. Abdullah Al Jamil. We know about Dr. Abdullah Al Jamil. He's a consultant in Asgar Ali Hospital. He's a 3 in 1, sorry. He's a clinical cardiologist and interventional cardiologist, also an AP specialist. And today, he's trying to be something more. He's going to challenge the pediatric cardiologist whether they can find out something wrong with his lecture. And I think the challenge will be accepted by our eminent pediatric cardiologists, and we'll be enjoying a very good interactive session. Thank you. And Jamil Bhai, you can start now.
Thank you, Professor Wadud. I shall talk about the abnormal ECG in children. I tried to include most of the abnormalities in my lecture, but maybe there are some deficiencies. As because it's a very vast subject, and hopefully it will cover everything. Can you see my screen?
Yes, sir.
Yes, you can see it.
দেখা যায়?
দেখা যায়, আপনি একটি স্লাইড শেয়ারে যান।
Okay, thank you. Today I'm going to talk on the abnormal ECGs in children. Diagnosis of abnormal ECG in pediatrics will require knowledge on normal ECG, what we have discussed in last Saturday. First, I come with the abnormal Q waves, that is atrial abnormality. In right atrial abnormality or right atrial enlargement, what is called the P pulmonale, the peaked P wave in lead to more than 3 millimeter from neonate to 6 months of age of the children, or more than 2.5 millimeter when the age is more than 6 months. Causes includes right atrial volume overload, atrial septal defect, Epstein's anomaly, of conference surgery. Left atrial abnormality or P mitral, wide notch P wave in 2, lead 2, or biphasic in V1, causes usually mitral stenosis, mitral regurgitation. So here is right atrial enlargement, is tall and thick, almost more than 3 small square, 3 millimeter. And in left atrial enlargement, there is a notched wide P wave, and in lead V1, it's there will be the terminal part will be deep and a little wide. Some atrial rhythms may have P waves in front of every QRS, but with an abnormal Q axis, that is invert, as for example, inverted in lead 2 and AVF, but upright in AVF. So this from the ectopic focus. This is an example of right atrial enlargement. You can see the tall peaked P wave is near about 4 millimeter, what is called P pulmonale, in lead 2, 3, and AVF. And this is left atrial enlargement. The terminal part of the P wave in V1 is deep and wide, and it is notched. There is a small notch in the tall peaked P wave in lead 2. This biatrial enlargement. Here the bifid P wave with amplitude more than 2 millimeter and duration more than 120 millisecond. It is clearly seen in lead 2 with a notch and on the top of this large P wave, and in lead V1, initial part is normal with it's not normal, it's peaked and sharp, and terminal part is deep and wide, indicating biatrial enlargement. Now the PR interval abnormality. Prolonged PR interval, that is first degree heart block. Usually more than 0.2 second or equal to more than 200 millisecond or one big box. This may be normal in some children. Viral or rheumatic myocarditis and other myocardial dysfunctions causes this. Certain congenital heart disease like Epstein's anomaly, endocardial cushion defect, or atrial septal defect may be the cause. Digital this toxicity and hyperkalemia. This prolonged PR interval, it is shown here, is quite long duration, more than it's near about 2 large squares. Short PR interval occurs in pre-excitation, as for example, WPW syndrome, that's Wolff-Parkinson-White syndrome, and another is glycogen storage disease. Variable PR interval occurs in wandering atrial pacemaker, this multifocal atrial tachycardia, and also in Mobis type 1 Wenck-Beck's phenomenon. This is a ECG of WPW syndrome with a short PR interval. In most of the leads, it can be discerned that there is a short PR interval and a delta wave. Variable PR interval is an example of Wenck-Beck. It is the normal in lead 2. This is the normal PR interval. It is slightly prolonged in next beat, and more prolonged in next beat, and then it is dropped. The P wave is there in the bottom panel, but no QRS complex, and again normal PR interval, gradual prolongation, and again dropped here. Prolongation of the QRS complex, the QRS duration. The prolongation may be due to bundle branch blocks, pre-excitation like WPW, intraventricular conduction defect or block, ventricular arrhythmias, ventricular hypertrophy, metabolic disturbances, and certain drugs. Diagnosis of ventricular hypertrophy by voltage criteria. So before going for the diagnosis, we have to have a knowledge on this chart. on this table the normal values of the pediatric electrocardiogram. According to age, it varies. The QRS duration increases with age, and the amplitude also it gets reduced gradually. From V1, the tall R wave and small S wave, with age it goes towards the adult phase, and in the V6 also similar reciprocal change can be observed. So for right ventricular hypertrophy, R wave height would be more than 98% of the in lead V1 for the normal amplitude of a R wave. From that previous table, we can calculate this, how much percentage of the amplitude is of the normal value. Then S wave in V6, similarly more than 98%. T wave abnormality. Example is upright in childhood. Causes are pulmonary hypertension, pulmonary stenosis, tetralogy of Fallot. This is an example of right ventricular hypertrophy. Here the arrow shows the tall R wave in V1, and it is more than 98%. This is ECG of a 10-year-old boy with pulmonary hypertension. Right axis deviation, it can be calculated from here. Then tall R wave in V1 and deep S wave in V6. Left ventricular hypertrophy, R wave height similarly more than 98 percentile for age in lead V6, and S wave in 98 percentile for age in lead V1. So it is the reverse of the right ventricular hypertrophy. The adult pattern R wave progression in the newborn, no large wave R waves and small S waves in the right precordial leads. Left axis deviation would be there. Causes are aortic stenosis, coarctation, ventricular septal defect, patent ductus arteriosus. Unrepaired, this is an example of an unrepaired coarctation patient with a deep S wave in V1 and tall R wave, 98 percentile. So it's example of a left ventricular hypertrophy. Other criteria for ventricular hypertrophies. For right ventricular hypertrophy, a QR complex or an RSR dash pattern in lead V1, upright T wave in the right precordial leads between age 7 days to 7 years, marked right axis deviation in association with right atrial enlargement, complete reversal of the adult precordial pattern of R and S waves. For left ventricle, deep Q wave in the left precordial leads, typical adult changes of lateral ST segment depression and Q wave inversion. RBH in a transposition of red vessels after mustard operation. Here you can see that a tall R wave in V1 and deep S wave in V6, and now the QT interval causes prolonged QTC interval are hypokalemia, hypocalcemia, hypothermia, drug treatment, cerebral injury, and congenital long QT syndrome, as for example Roman-Ward syndrome. This prolonged QT interval, as shown here with arrow, this is the interval of two QRS complex. It is more than half of the RR interval. Causes of short cure interval, QTC interval, is hypercalcemia, digitalis effect, congenital short QT syndrome, as for example, genetically inherited channelopathies. Other associated features of the QT abnormality includes notching of the T-wave, abnormal T-waves, relative bradycardia for age, T-wave alternance. These children may be at risk of ventricular arrhythmia and sudden cardiac death. Here is an example of prolonged QT interval with alternance of T-wave. This previous T-wave is upright. Here it is negative, and it's again upright, again negative. This T-wave alternance with long QT interval. Abnormal Q-waves. Q-waves in other than leads 2, 3, ABF, V5, and V6 are rare and usually associated with disease. That is, in these 5 leads, normally Q-waves are present in children. Q-waves are abnormal if appear in the right precordial leads, as for example in V1, that is severe RVH, are absent in the left precordial leads, as for example left bundle branch block, are abnormally deep ventricular hypertrophy of the volume overload type, are abnormally deep and wide, as for example anomalous left coronary artery, or myocardial infarction or fibrosis secondary to Kawasaki syndrome. Pathological ST segment changes commonly associated with T-wave changes. This occurs in pericarditis, myocardial ischemia or infarction, severe ventricular hypertrophy, ventricular strain pattern, digitalis effect. Abnormal T-waves may be tall, peaked T-waves, occurs in hyperkalemia, left ventricular hypertrophy, volume overload, benign early repolarization. This is a normal, considered to be normal. Flat T-wave seen in normal newborns, hypothyroidism, hypokalemia, digitalis, pericarditis, myocardial ischemia. Large, deep, inverted T-waves are seen with raised intracranial pressure, as for example intracranial hemorrhage, traumatic brain injury. U-waves, most common causes include hypokalemia, normal finding in slower heart rate, that is sinus bradycardia. This is the Q-wave after T-wave is clearly visible here in a bradycardic patient. Characteristic ECG pattern for particular conditions, as for example pericarditis. Subepicardial myocardial damage causes the time-dependent changes in ECG. Initially, PR segment depression, widespread concave ST segment elevation. Later, T segment returns to normal within 1 to 3 weeks of onset. Flattening of T waves, then T wave inversion with isoelectric ST segment after 2 to 4 weeks of onset. This is an example of acute pericarditis. Here the ST segment elevation with concavity upwards and ST depression with convexity upwards in AVR, and widespread in many of the leads, especially the left-oriented and inferior leads. These are clearly visible. In myocarditis, ECG findings of rheumatic or viral myocarditis are non-specific and include AV conduction disturbance, prolonged PR interval to complete AV dissociation may occur, low QRS voltage, 5 mm or less in the all limb leads, decreased T wave amplitude, QT prolongation, tachyarrhythmias like supraventricular tachycardia or ventricular tachycardia, pseudo-infarction pattern with deep Q waves or poor R wave progression in precordial leads. Myocardial infarction or ischemia, same changes as that of adult myocardial infarction or ischemia. In infarction, ST elevation in contiguous leads and reciprocal ST depression elsewhere, and in ischemia, horizontal ST depression. A wide variety, there is full range of dysrhythmia may occur in a pediatric patient. This from premature contraction, that is atrial and ventricular, tachyarrhythmias, the supraventricular tachycardia, like sinus tachycardia, supraventricular tachycardia, this paroxysmal atrial tachycardia, atrial flutter, atrial fibrillation, junctional tachycardia, ventricular tachycardia and ventricular fibrillation. Bradyarrhythmias, sinus bradycardia, junctional or nodal bradycardia, conduction abnormalities like first degree atrioventricular block, second degree atrioventricular Mobis type 1 when Quebec or type 2, third degree AV block. All this may happen in a child. Thank you all for patient hearing.
Thank you, Dr. Jamil, for your brilliant presentation. It was a brief.
Firod, Professor Shakil Ahmed, pediatrics professor Dhaka Medical, he has joined.
Yes, thank you very much. Wadud, thank you very much for giving me the opportunity to join here. So,
Professor Shakil is professor of pediatrics in Dhaka Medical College. I was just a little bit late to contact him. Anyway, Jamil Bhai, can I ask you a simple question?
Sure.
In adults, we consider that sinus tachycardia is when the rate is sinus and rhythm is sinus and rate is more than 100. And how can you determine this sinus tachycardia in a particular age group in children? Or any of the panelists in the pediatric cardiologists?
Let me say something. Last week we discussed about this rate, or it highest in the neonates, and gradually it comes down and becomes almost adult heart rate after 6 years, after 6 to 10 years. It becomes heart rate becomes almost adult rate. So we have to keep that chart in our head, and in what age group, what is the range. It's very difficult to memorize, but probably pediatrician always practice and they can recollect very easily. We don't practice, so we need that chart nearby.
Now, my point is, how are we going to make the diagnosis of sinus tachycardia in these patients? What should be our writing pattern in reporting the ECG? Nahruma or anyone, can you answer it?
So I think previous session, Dr. Rezwana Rima mentioned a Z-score of calculator that we have.
Atahar,
We can use that things.
can you say?
Plus two Z-score, that will be sinus tachycardia. If P is present and more than +2, then bradycardia.
Yeah, I forgot it. Yes, you have told. Rezwana Rima was actually.
There is a scoring system.
But can you send that scoring system to Dr. Review, so that we can have that, all of the participants can have that score.
It's in the net, sir. Pediatric G-score is in the net. Anyone can use it.
In Google, sir.
You just Google and PED Z-score like that.
PED Z score.
Apple's also another parameter Z, and in Google just Z-score calculator of heart rates.
Yeah.
আমি একটু জাস্ট রিমা অথবা নাহরুমাকে একটু অনুরোধ করবো
Also,
লিঙ্কটা
friends and doctors, oh, yes, speaking.
ভিডিওটা অন করেন শাকিল ভাই, ভিডিওটা অন প্লিজ।
or Naruma to just put the link on our site so that all the participants can know where to go. That's clear for them. Thank you very much. Just go up a little bit and collect it and give it to anyone.
Okay, sir.
Slide করে যদি just slide project করলে সবাই দেখে নেবে। Thank you.
শাকিল ভাই আপনাকে একটু দেখতে চাই, ভিডিওটা অন করেন।
আমি তো এখানে প্রস্তুত অবস্থায় আছি।
হ্যাঁ শাকিল,
জি আসসালামু আলাইকুম।
দাড়ি গোঁফ সব সাদা হয়ে গেছে।
জামিল ভাই,
হ্যাঁ
গান তো এখন শোনা যাবে না, গান এখন আচ্ছা আমরা কথা শুনি।
Another question is that I'll be asking the different sort of arrhythmias. Let's say a child has come with fever. When we should be concerned, what sort of arrhythmias you think is a very serious thing? Because a child with fever may have some degree of arrhythmia. What are the things that you see in the ECG that will really concern us?
Sir, for arrhythmia, the same way we, the adult, the way you diagnose an arrhythmia is like normal upright P-wave axis is normal, upright P-wave in lead 2, and there will be P-wave before QRS complex. And the rate, last session I have said that the maximum sinus rate a person can would be 220 minus age in years. That is a simple thing you can do, and whenever there is an upright P wave before every QRS complex and the P wave axis is normal, this is sinus arrhythmia up to 220 for a neonate. And but sometimes like 150 can be a abnormal arrhythmia, like in neonate and early infancy we encounter different kinds of arrhythmia like junctional ectopic tachycardia, PJRT, and atrial ectopic tachycardia, multifocal atrial tachycardia, and this rate may be lower than normal, like that 150 to 200 to 220 can be an arrhythmia. But in that case, like junctional ectopic tachycardia, there will be AV dissociation, and PGRT there will be inverted P wave in lead 2, 3 AVF, and we know atrial tachycardia there will be long RP tachycardia, short RP tachycardia. That way, I mean the P wave axis will be changed in PGRT patient or atrial ectopic tachycardia. There will be abnormal P wave or P wave morphology should be changed. The same way the adult diagnosed as a tachycardia, we diagnose in the same way. So I just want to add with Dr. Jamil that we are getting a lot of tachycardia-induced cardiomyopathy. So nowadays we are getting, whenever we get a child with a cardiomyopathy, we used to do an ECG to check whether there is some form of tachycardia, whether this is a kind of tachycardia-induced cardiomyopathy or not. Especially permanent junctional reciprocating tachycardia that we know as PJRT. So like 150 to 200 rate would be enough to form this, because these are incessant tachycardia and they causes tachycardia-induced cardiomyopathy. We are encountered a lot of tachycardia-induced cardiomyopathy cases nowadays, and even fetus also comes to us at 30 to 35 weeks around 28 to 30 weeks gestation with hydrops with tachycardia-induced cardiomyopathy and hydrops. So that also we need to terminate in utero. For that, we have some other protocols. And in neonate also, neonate are at 2 months of age. Sometimes some children after myocarditis came with tachycardia-induced cardiomyopathy. So it's difficult to understand whether this myocarditis leads to cardiomyopathy or there is some form of tachycardia is also there. So these I just want to add.
Another question is, we get a lot of patients, children particularly, with diarrhea. And with diarrhea, what sort of arrhythmia do we usually get? And should we be concerned too much about that?
With diarrhea,
we don't see those.
That will be related with electrolyte imbalance.
Yeah.
That's what I was asking. And do you get that much of an arrhythmia?
With diarrhea.
Are they more prone to develop hypokalemia more than the adults, that young children?
Yes.
I want to have some idea, because our audience will be in the peripheries and everywhere. Sometimes they have to give some judicious answer to that particular problem. So your discussion will be very helpful for them.
With dehydration, diarrhea with dehydration, sometimes we find a sinus arrhythmia, but with hypokalemia, not much of arrhythmia, but there would be some the ECG change with hypokalemia or hypernatremia, the same ECG change that is happening with adult. No, I haven't encountered any arrhythmia other than sinus arrhythmia with dehydration and diarrhea.
That means you don't get that much of ventricular arrhythmia in these patients.
I mean, there is no rhythm disturbance. There may be some STT. I mean, there may be some changes because of electrolyte imbalance, but we don't routinely do ECG in a diarrhea patient unless there is a rhythm disturbance or any kind of deviation of the heart rate from normal range to, above the normal range or below the normal range. Otherwise, we don't routinely do ECG in a diarrhea patient.
That we do not in a diarrhea patient. In post-operative patients, sometimes in emergency situation where ABG machine is not working, that ECG helps. If there are any tall P wave QRS or on that helps us, electrolyte imbalance.
Today, one thing I want to draw everyone's attention.
Can I add a little bit here?
Shakil bhai, please.
Add with the Rejwana Rima, diarrhea, the problem of diarrhea is loss of water and electrolytes. I've got a request to all doctors who are listening to me, go for an ECG, go for replacement of fluid. And it's the primary thing. You want to do an it's very question from Wadud. I think there is no literature so far as I can recall. There can be research on other things. So for that perspective, those who are interested in research, they can go for an ECG that side. But
do you know
the periphery, go for water and electrolyte replacement fast in any dehydration before going to do an ECG. Thank you very much.
Why I was saying actually, nowadays use of the pulse oximeter has become very widespread. So in the pulse oximeter, we are getting the level of abnormal beats and everything, and also seeing the pulse wave. That actually is drawing attention to many of the parents and also the doctors. Nowadays, it was not before, but nowadays it has become widespread. And you can rest assured, this pulse oximeter use will be continued even after the COVID era. So I think our pediatric cardiologists will be getting more call for that.
Yes, sometimes some worried patient came to us with a pulse oximeter that showed that the baby's heart rate is 120. So we have to explain that this is within normal limit. We have to do the G-score and say that, okay, this is normal for the child. Because of, sorry, you are correct. Now this era, a lot of patients come to our OPD that they check the pulse oximeter and they found the heart rate is 120. So they get very worried and come to us.
I'll be asking another question that's out of my curiosity. We have to use different sort of antibiotics and other things in case of children. And does that lead to any problem, Shakil bhai, in your experience? Any cardiac problem whatsoever?
Can you repeat the question, please?
We use different sort of a antibiotic, and nowadays antibiotic is so widespread. Does that lead to any particular problem in case of children regarding the cardiac function and rhythm? Shakti, hear you.
We haven't encountered anything in the case reports and other things from Bangladesh on this issue. But there are a couple of case reports from outside Bangladesh. With erythromycin, the children have electricity problems. For malarial, as its use of the antimalarial in Bangladesh has been very much and limited to very few areas of Bangladesh, only in the Hilpes area. So currently, we are not encountering those things as well.
Actually, sir, we are very reluctant to do an ECG for a child. That is the problem. Whenever possible, we are doing an echo. I mean, so that's why ECG is underestimated, or so we don't know actually what are the ECG changes with any antibiotics or any drugs.
I hope my question will be encouraging you to do that, and we want to have some insight regarding that.
Sir, we have found a patient of infective endocarditis that we are giving a vancomycin, sir. Was causing arrhythmia junctional, I think. So I remember, sir, that we have to stop that vancomycin, sir.
One thing I have learned from Rafiq sir, that whenever you get a child or anyone with a tachycardia, if the rate is too much fixed at one point, you should check out whether it is sinus or not. Most likely it's not sinus, because sir have taught us, and now it's been ingrained in our mind. Sinus tachycardia will vary because of the autonomic tone. It will not be fixed at a 130 per minute continuously. It will be 130, 35, 140, something like that. But if you get a child, as Rajana was saying, we are getting a lot of tachycardiomyopathies. I think this is very much underdiagnosed in this country, because I have some experience with this type of patient, and I have sent those to pediatric cardiologists. That tachycardiomyopathy in the children, young children, around 6-year-old, 5-year-old, 10-year-old. And I think this is very much underdiagnosed in this country.
Can I add one point? Sinus tachycardia, I get many patients, but I tell them count their heart rate pulse during rest and during sleep. And I have to, I sometimes exclude thyrotoxicosis, stress, anxiety, whether exam is there or not. I exclude these things.
Sir, do you want to make a comment, sir? Rafiq sir? Sir, unmute, sir. Unmute, sir. Sir, you have to unmute.
Can you hear me now?
Yes, sir.
Yeah.
So one of the important things is the PGRT. You remember in adult, we rarely see paroxysmal junctional tachycardia. It's more common in children. But also we have to remember what we call PGRT. Is it really true PGRT or some form of AV node reentry or incessant other tachycardia? Because the patients that we see are the adult ones. But a lot of these patients with concealed accessory pathway AV node reentry will have this as a child. I mean, youngest patient that I have done ablation for WPL is a 1-year-old child. And the patient had incessant tachycardia that we are forced to do. We had a choice between doing giving amiodarone with its side effects versus ablation, and we did ablation and it worked fine.
Sir, actually what Rajana Rima added, that is the tachy-induced cardiomyopathy. Possibly that is the combination of the cardiomyopathy and the tachycardia is not uncommon. That is commoner in children than the adult. So the question is, sir, what are the common arrhythmias that are responsible for the tachy-induced cardiomyopathy in this group? It is difficult to prove which one is the primary, that is the tachycardia. But if the tachycardia is the cause, then what are the common arrhythmias? She expected that the PGRT is one of the common. Then the other causes, sir?
No, I mean, when we say PGRT, basically because we cannot see P wave. So in adults, you can see what we call true junctional tachycardia. That means the AV node has become faster. It's not a reentrant arrhythmia. But then again, you can have a significant number, which actually is avinodal reentrant tachycardia, or atrioventricular reentry using concealed pathway. And even though it is more common to see tachycardia cardiomyopathy in children, I have seen adults with tachycardia cardiomyopathy. They have no symptom at all, with heart rate of 130, 140. But I think these patients get used to it. So etiology in the spectrum, we should consider all the etiologies except flutter, atrial flutter in children also.
I found some junctional ectopic tachycardia with cardiomyopathy, some multifocal atrial tachycardia with cardiomyopathy, and atrial tachycardia with tachycardiomyopathy. So I have a spectrum of 8 to 10 patients. I can present if if you permit, then subsequent any session. I have the ECGs also, and it's very interesting.
What we should do next week, because we are doing pediatric ECGs, why don't you ask Dr. Rizwana to present the cases? It will be very interesting, a continuation of the lecture series.
Rima, can you present it next Saturday?
Yes, sir. I will try. Yes, sir.
No, we'll be happy. Actually, next Saturday was scheduled for Rofik, sir. But I think if you are ready, then we can change the date. That is, the Rofik will present later, and you are welcome for the next Saturday. Are you ready?
Yes, sir. One half I can present, and the other half sir can present. I mean,
Nahruba, can we add something more? Also, the other pediatric cardiology. If you want to add something, we'll be really, really grateful, and we'll be enjoying that. We'll be looking forward to that.
Sir, there are few tips for the adult cardiologist and pediatrician, sir, and mostly adult cardiologist, sir. Like echo, we also see the situs axis, and that Atahar Ali, sir, on that day is telling how do we come a conclusive diagnosis by seeing a ECG, because we know the ECG can tell about the chamber dimension, hypertrophy, all this, but in pediatrics, it is very important. Sometimes we have to decide by ECG situs, atrial situs is present or not, ventricular levocardia is present or not, and also we have to see that is the patient is like ASD, VSD operable or not, or by classifying the type of the ASD or VSD, we can easily do on that case, or sometimes by seeing the loop, that clockwise loop and counterclockwise loop. That also we see in the ECG, and we with the help of the ECG we can see this.
And Nahruma, can you, with case a few cases, can you present some of those? So then Rajwana, Rima, and you two will be having very good session.
Okay, sir. That will be help, sir, because very complex congenital heart disease that we can easily diagnose by the ECG. By tricuspid atresia, we can see right axis deviation, left axis deviation with.
Don't rehearse now. Keep it secret. We'll be looking for that.
Sir, then sir, next Saturday, that is speaker will be Rajwana, Rima, and Naharuma.
Yes, that'll be good.
Hasan Murad, Hasan Murad তোমার ই করতেছিল, হাত করতেছিল.
Sir, we can. There are two pediatric cardiologists from Nepal, sir. Monish and Urmila.
Ah, yes.
Manish and Urmila, please open your video, please. Manish and Urmila.
Ah, yes, they are there. Welcome.
Good evening. I really nice to participate in today's program, like last time also. Yeah, today there is very good discussion about a different kind of disease, and it's showing the abnormality of the ECG. Is very, very nice, and it's very challenging to do ECG in the small case. Mostly, for example, in very uncooperative child, if there is mostly they have some anxiety component when they are separate from the parents, like that. In such cases also, most of the time we can get the artifact also. But even though that, the ECG is very, very important. Sometimes after doing echo also, we cannot have the ECG get done. So sometimes after doing the echo, sometimes if we can get the abnormality in the ECG, sometimes it may change our echo diagnosis also, or there may be something we have to go on searching if there is any misdiagnosis or some is lacking. So though it's challenging, and most of the technician also, they are not willing to do ECG in a small case due to some technical problem. They are very uncooperative like that. But even that, it is very, very helpful, and it can support our diagnosis very properly. So it should be give many focus on the ECG besides the directly go on the doing the echocardiography. So this type of webinar for this all pediatrician as well as pediatric cardiologists are very important, because we are not seeing much of the pediatric ECG regularly like the other investigations. So it's very, very important, and it's very nice to have this type of this program. So thank you very much.
Urmila, do you do the ECG in all the cases, or as because the echo is the most useful test for the diagnosis? All the pediatric patients are done echo, but not all the patients have got the ECG. Do you do that? Is the ECG and echo both the cases? That is all the cases, or you do the only echo?
In the principle, that basic investigation after the history is the ECG and chest X-ray. Then we have to go for the echocardiography. But due to the technical problem and small case very uncooperative, so sometimes, yeah, we are not going to do for the each and every pediatric cases. But if it is necessary, like some kind of doubtful in the conduction disturbances or tachycardia or very bradycardia, which cannot be explained by the other methods. So at that time, however, it is very difficult. Then we try to get the ECG.
Manish, unmute please, Manish.
Dr. Please unmute yourself.
Manish, we cannot hear you. Can you unmute, please?
Good evening. Yeah, most of the things has already been said. That's everywhere is true that it's really difficult to do ECG in each and every cases. That's very true, because we have to sedate them because they are very uncooperative. So as the Dr. Urmila and other pediatric cardiologists mentioned, that only in needed cases, only in where the ECG is really helpful, we are doing in those cases. All cases we are not doing, but it's always better to have ECG and X-ray first before echo. But we are going opposite, because it's in day-to-day practice is really difficult in small children actually.
One of the questions from the audience is, what are the indications there where we have to do the ECG with all the problems? Can anyone answer that?
Yeah, it's like the most important indication is the arrhythmia. That is the one part where we cannot diagnose by echo. That's the most important indication. Apart from that, yeah, as Dr. Naharuma has mentioned, that we can diagnose the complex congenital heart disease by ECG, but eventually we have to do echo. Or we can suspect congenital heart disease by ECG, that's true, but we have to do echo. But in arrhythmia we cannot diagnose by echo. So arrhythmia is the most important indication in my opinion. Apart from those, yeah, it's helpful in other cases also.
Before surgery, we used to do congenital heart surgery. Before any congenital heart surgery, we used to check the ECG whether there is any the sinus rhythm, and sometimes the heart rate is in the lower range. So sometimes we fail to pick up the heart block, like 2:1 heart block. So routinely before in cardiac surgery, we used to do ECGs. That is one more.
Also before any intervention, cardiac
intervention, yeah.
Exactly.
And those who are working in our like specialized hospital, every patient we do who came to in OPD, because all of the patients have form of syncope, feeling unwellness or occasional palpitation, history of family history of congenital heart disease and restlessness. All these symptoms we do a routine ECG. We don't do the routine echo for all patients, but we do a routine ECG, sir.
Thank you. Sir.
Yeah, can I make a comment? I think what's happening, I mean, it was true for every country that pediatric cardiology was mainly focused on congenital heart disease, but not the not the other part. It was always perceived that a pediatric cardiologist would be congenital. But children can have MI, children can have arrhythmia. I mean, that's something that we are expanding. That I think as time passes by, we'll have more and more patients, the family is more conscious. I mean, if somebody has palpitation as a child, people will most of the time will ignore it. Well, nothing, it's just a palpitation, we're running around. So I think more and more we'll see other problems that will require that we do ECGs. Can I ask you a question about pediatric cardiology in Bangladesh and Nepal? All of you who become pediatric, did you train in pediatrics first and then become cardiologist, or you trained as adult cardiologist, became pediatric cardiologist?
Mother subject is pediatrician, sir. I'm a pediatrician. Then I have do fellowship 1-year course and in pediatric cardiology, sir.
Yeah, that's fantastic. Because I think this is the one of the flaw. It's not a flaw in the way it happened in Bangladesh, that adult cardiologists are not trained in medicine. And I think that's a gap. Because but I think any subject specialty should be, somebody should be pediatrician first and then pediatric cardiologist. Likewise, a surgeon, cardiac surgeon should be general surgeon first, and then you become cardiac surgeon, because then you see the patient as a whole. Here in the United States, I can take care of diabetes because I'm trained in internal medicine first, and I cannot become a cardiologist unless I am board certified in internal medicine, and which is, I think, I'm very happy to hear that you came from pediatrics and you did cardio. That makes it complete, because then you look at the patient as a total patient, not just looking at the heart. I'm very happy to hear that.
Before going to next session, I want to hear one thing from the Naveen Sheikh. Naveen Sheikh.
Sir, actually, I am in the Department of Adult Cardiology, but I have completed my fellowship from NUS Singapore and Asgar Delhi in pediatric cardiology. Now I am working adult cardiology. What I think that we have to remember that what are the common variations in rhythm which may be normal in children, like sinus arrhythmia or short sinus pauses, which Dr. Jamil Bhai has already mentioned, first degree block. Another thing is sometimes we get notched P wave in 25% pediatric patient it lead to. That is normal for those kids. And also like Winkeback, then first degree AV block, it can be a normal variant in 10% of the kids. These things we have to remember, like junctional rhythm or supraventricular or ventricular extrasystoles. Usually they disappear during exercise. And another thing is already Dr. Naruma already mentioned that by ECG we can assess. Actually ECG always should be interpreted. I think that along with clinical and radiological data, then we can understand what hemodynamics changes occurring in particular disease. We can assess the severity of the disease in case of like stenotic lesion, aortic stenosis or pulmonary stenosis. And in case of operable and inoperable cases, if operable, then there will be shunt anomaly. In case of shunt anomaly, pre-tricuspid or post-tricuspid, there will be left-sided precordial forces will be higher than, and there will be Q waves present on the left-sided precordial leaves. It means that there is increased pulmonary blood flow. Patient has not developed pulmonary vascular obstructive disease. But if there will be diminished Q waves on the left-sided leaves and the right, there will be RV dominance, Doll peak. In that case, also we have to check the saturation also. If saturation less than 90, we can get information that the patient is inoperable. It is a very easiest way. And another thing I want to add that in case of AV nodal block, it can occur as a familial or non-familial. Some family members, we have seen that ASD with first degree heart block, but another with intact septum, but PR prolongation. So we have to keep in mind what are the normal variation in the rhythm. Thank you.
Thank you.
Can I make a comment?
Sir.
Yes, sir.
I think Dr. Naveen made a very, very important point that we should all remember. When we report ECG, we always, I don't see the patient, I say clinical correlation is needed. But she said that you cannot just look at an ECG, you have to think of the patient. I mean, to get more, so please remember in our audience for the junior doctors, that ECG by itself is just a test. You have to correlate with the patient's clinical scenario. And that's very, very important.
Like early repolarization, sometimes we get that early repolarization, just like pericarditis, right? Am I right, Jamil bhai?
Yes.
I think point elevation like this, something like this, that is normal. No, but we have to understand which finding we will get in pericardial effusion. It is early repolarization. It's normal. Also, the poor progression of the R wave like this. So many things we get. No, there is as because it represents the dominance of the LV function, and another is sinus arrhythmia. I get so many ECG when I do the report, sinus arrhythmia. The sinus arrhythmia, we have to understand that during inspiration, vagal tone is decreases. Also in obesity, diabetes mellitus, hypertension, we can get this sinus arrhythmia. Though it is common between 3 to 30 years of age, but it is most common in children. And another thing Dr. Naharuma has mentioned very nicely, that ASD, I wanted to say about it, that ASD, we can divide it into two, like clockwise loop or counterclockwise loop. And clockwise loop will be present in ASD secundum. And in sinus venosus ASD, there will be clockwise loop, but P wave will be inverted in, I think, lead 3. Naruma, lead, and in counterclockwise loop, like ostium primum ASD, and another cause I don't remember. This way, ASD can be divided.
Show us this ECG in the next class. So we will wait for another 7 days. Now we can move, I think, to our next session.
Wadud, I wanted to say something. Firoz, before going to next session, what to say?
হাসান মুরাদ একটা হাত তুলছিল, ওদের কোশ্চেন করতে চায়।
Hasan Murad, are you with us? Are you in the? Do you want to ask any question? Hasan Murad? He is not here, sir.
That's all right. We should start. We are waiting for Rafiq sir session.
Yes, sir.
So Naharuma, Rima, next Saturday, please. This is the
Inshallah, sir.
Pediatrician, including our Shakil bhai, Urmila.
Abhishek, you are always welcome. Shakil bhai, always welcome. And Manish and Urmila.
Can you see my slides?
Yes, sir.
Yes, sir.
So I'm sorry, I'm not a pediatrician. I did 2 months of pediatrics and I loved it as an intern. But I think there is a lot of overlap in cardiology, and one of the fields that we need to develop in Bangladesh is a specialist in adult congenital heart disease. That means when the pediatricians see the heart disease patients, once they become adult, they should be moved to the adult. So that's a spectrum. So I'm going to start with one ECG. Nothing to do with this one. And I have given some choices here. And then we'll discuss this ECG. This is a 79-year-old male with history of cardiomyopathy, ejection fraction around 25%. And I have put the heart rate in the bottom is 115 beats per minute.
Can we start the poll? Remove, I guess.
Firoz, ask the person to answer. Anyone, no problem.
So the answer 64% said it is atrial fibrillation with right bundle branch problem.
Okay, so I'm going to leave it. I want to see that. Please keep that number there. I would like our panelists. So The question would be, all are valid choices, otherwise I would not have put those choices. The question is, what is the most reasonable choice? I want our panelists to comment on this ECG. This is a very interesting ECG.
Sir, the rhythm is clearly irregularly irregular, and we cannot see the P wave.
Okay.
That is the clean cut P waves are not visible, and the rhythms is clearly. So I am my first choice is atrial fibrillation. Number 3 is clearly out.
Okay.
Number 3 is clearly out. Then ventricular tachycardia, I think this is also we can clearly out this possibilities. Then the number 1 and 2.
Look at you.
And between these two, I'll choose the atrial fibrillation as because there is no P wave and it is irregularly irregular.
Anybody else?
Otherwise,
the pattern of
pattern is no, that's fine. That is fine.
Sir,
what is your comment?
My comment, I go for the number.
Jamil will be last. Jamil, you will be last. Who else?
Sir, can I make say something, sir?
Yes.
Sure. Can you turn your video on?
Yes, sir. Sir, am I audible?
Yes, audible. Yeah.
Yes. Okay. Sir, the rhythm is irregularly irregular, but if I look at the lead V1,
yes,
the baseline that looks like the flutter-like wave.
Okay.
So for that reason, my first differential diagnosis will be atrial flutter with variable conduction.
Okay. Yeah. So I mean, those are all possibilities. So anybody, unless anybody else is there, I'll ask Jamil.
Sir, I want to add one point, sir.
Another observation.
Yes.
In rhythm strip, there is sort of group beating, 2 beats and a gap, then another 2 beats, another and a gap and a 2 beats.
Exactly.
Brings the choice of atrial flutter with variable block or sinus rhythm with atrial premature.
Okay.
Is unlikely of atrial fibrillation.
Okay, sure.
Sir, everything already discussed. One point I want to notice here, there is the RBB, but the axis is the left axis deviation.
Yes. That's interesting finding.
Yes, sir.
So we'll keep that finding in the pocket and we'll come to the discussion. Jamil, any comment?
Sir, I noticed what Firoz mentioned. I want to go on that point only. That to me it seems it's bigeminal type atrial tachycardia.
Okay.
Yeah, one beat followed by another, and there is a pause.
Sure.
And there is tachycardia, so the pause is a little narrower.
Yeah.
So I go for the third choice.
Right. Okay. So I mean, I'm going to go and by system. I think all are valid choices. The problem with atrial fibrillation, you see, there is a pattern.
Sir.
Short interval, long interval, short interval, long interval. So it is not irregularly irregular. So I think, even though suddenly I look at it, looks irregular, but it's not irregularly irregular. So I think atrial fibrillation is probably out. Now I can have atrial flutter with variable conduction, as it was mentioned. Maybe this is a flutter wave, if you can see my pointer, and this is another flutter wave, this is another flutter wave, and so on and so forth. And of course, sinus rhythm or an ectopic atrial rhythm with premature beat, but there is no P wave. Now, even though this suddenly looks narrow, but it is actually a wide QRS, 160 millisecond, and then that is left axis deviation. There's an important point. So I have now I'm stuck with, is it ventricular tachycardia or is it, because one of the problem with right bundle, it should have right axis deviation. It's not. Lead 1, I don't see terminal SO wave, but it still can be right bundle. So let's look at these few things. So my problem now is it a supraventricular rhythm? Whatever it is, atrial flutter, sinus rhythm, or ectopic or ventricular tachycardia. So I'm going to look at few points to make my case. So is there precordial concordance? That means in limb leads, in chest lead, are all of them looking up without any RS pattern. In this case, the answer is no, because in V6 there is RS pattern. So there is no precordial concordance. So that goes out. My next choice is the onset of R wave to the deepest point of S wave, is it more than 100 milliseconds in any precordial lead? I have taken this complex and have expanded it, and you can see that is 120 milliseconds. So that fulfills criteria for VT. But remember, all these criteria, none of them are 100% correct, but that's a possibility. So next look, so I'm going to take it a yes and maybe VT. But let's look at, is there AV dissociation? So I'm going to bring that ECG up again. It is very difficult to find AV dissociation unless I'm very imaginative, and maybe this is a P wave which is absent here, but that's a little bit of stretching the imagination quite a bit. But I cannot use this point. Second, next I'm going to look at, is there morphology criteria for VT in V1 and V6? And these are the morphology criteria that is, if it is right bundle type, this pattern, either monophasic R or QR or RS pattern in V1 and RS less than 1 in V6 suggest VT. And I'm going to superimpose. This is right bundle type, and if you look at lead V1, it's a QR pattern which fulfills this criteria of VT. So this patient actually had a VT, and I have confirmed it because patient had a defibrillator. And when I do the intracardiac on the same day, I could see the AV dissociation. So this is an unusual case. Now the question is, why is it irregular? That is the problem. So morphology criteria fulfilled, VT. This one fulfills. I have two criteria fulfilled. And actually, in other ECGs, I could say AV dissociation, two criteria. So this is ventricular tachycardia. Now, let's look at it. Why is it irregular? So VT happens normally with a scar. And I have drawn if you shaded area are the infarcted tissue, and white area is where it can conduct electricity. And so in a scar, I can form a re-entry circuit. And it produces a QRS complex as it comes out. And if it went back through the same circuit again, it will produce another QRS interval and another one at a regular interval. But what can happen that you can have a two entry point in the same scar. This time it was blocked, and second time it comes back through this shorter circuit, it will come earlier and produce this earlier complex. And then it goes back to the circuit, uses another pathway, and then produces the second. And you can actually see VT with irregularity because there is two entry point in the short circuit. If the exit, sometimes you can see bigeminy with a different morphology QRS, that means the entry point is correct, but the exit are two different. And that is the explanation for this. So anybody, any other question on this?
Rohik bhai, it is the posterior fascicular VT neki.
Well, the patient, it is fascicular VT is a possibility, right bundle left, but or a scar near that area, because fascicular VT will be a little narrower. This was 160 milliseconds. This is a little wider, and this patient has history of MI with scar VT. We studied this patient.
Can it be WPW with AF?
Well, okay, yes. If it was AF with WPW, the diagnostic criteria AF with WPW, irregular RR, irregular QRS width. In this patient, the RR is irregular, but the QRS width is not irregular. Anytime we find something with white QRS tachycardia with irregular RR interval, if the QRS width is irregular, that is WPW with accessory pathway conduction during AFib. But this one is basically not WPW syndrome. But definitely that's a consideration because it looks like, here it looks like pre-excited beat. but all the QRSs look similar.
In WPW, Rafiq bhai, typically the antidromic conduction with presenting with AFib and white QRS looking, usually the rate is very high, like
exactly
190 to 200.
Yes, yes. This is a very slow VT. This is a very slow VT. This patient had VT as slow as 100 beats per minute. And this was the interesting case discussion. All right, so we'll go to another ECG. I'm going to start with simple ECG and then move on.
Sir.
Yeah.
Sir, if you don't mind, can I ask a question?
Yes, sure.
So if this ECG is given to us,
yes, yes.
So commenting other than AFib or atrial flutter as a rationality, can we comment VT other than AFib or A flutter with variable conduction?
The diagnosis is ventricular tachycardia. That is the diagnosis. So no question about it. So this is ECG. We want some answers. And I hope this will be 100% correct. I think we need to remember, audience need to remember that during this discussion, we are not only going to show complex, difficult ECGs, we will also show simple things. And what do you think?
80% says it is atrial paced rhythm.
Okay. And anybody disagreement with that?
10% dual chamber pacemaker and 10% sinus rhythm with left atrial enlargement.
So, at least I'm happy that nobody said ventricular paced rhythm. That's fantastic. And then, of course, dual chamber paced rhythm will come to that, but majority says atrial paced rhythm. With the atrial pacing, to look at the rhythm strip in the bottom, atrial pacing spike, there is a P wave, there is QRS. There is no ventricular pacing spike. Basically, it can be a dual chamber pacemaker, but I cannot comment on that. So this is actually atrial paced rhythm. Thank you. Next one. This is actually a good distribution.
Yes.
All right. So I'll leave it to
Wadud.
I always look at the lead one. The QRS complex is narrow and it has a P wave. The three QRS complex all have P wave, so it's a sinus rhythm. But we have some big complexes, so there are some PVC as well. Now, the point is there left atrial enlargement? Because sinus rhythm, left PVC, we are all getting that. For left atrial enlargement in V1, the negative part is not that big. I'm not that convinced. It could be. But one thing that looks very prominent is that as a whole, the complex is very smallish. So if somebody says sinus rhythm with low voltage PVC and some non-specific T-wave changes, I would rather go for that. And look at 3 and also AVF. There seems to be a smallish Q wave. This could be an old inferior MI as well. Because the voltage is quite all right. 1 millivolt equal to 10 millimeter tension as well.
Anybody else? Any comment?
I like to go with the third choice, atrial pace.
Lead V1. What is happening? Lead V1. There is some spike before the.
Yes.
There is one spike in the third wave.
No, there are a lot of spikes in the lead 3.
Okay, I'm going to move this ECG. This is what I have done. I have expanded V1.
And this here, yeah.
And if you look at the rhythm strip, so this makes a point. Modern ECG machines filtering is
problematic.
And also because of the bipolar pacing, and also not only that bipolar pacing, most of the pacemakers have auto capture. So in the old days, we program pacemaker at 2.5 volt. They don't necessarily program at 2.5 volt. They program at a very low voltage, like 1 volt, 1.2 volt, a little bit above safety margin. So and if you see that I kept the report. This was a report confirmed by cardiologists, and that's fine. I mean, that is something that we will miss sometimes. But when we see some artifact, we should look back and to see if we can see it somewhere else. So it was basically an atrial paced rhythm and PVC with the low voltages. Thank you.
Vik bhai, I have done this trick with the calibration 25 millimeter speed. I go 50 and then make a SVT looking like VT.
Okay, how about this one?
রিফু তুমি পোলিংটা একটু পরে দিও 20 সেকেন্ড তুমি 20 সেকেন্ড দেখার পরে 10 সেকেন্ডের জন্য দিও, তাহলে সবার দেখতে সুবিধা হবে। V1
We'll continue until what time?
10:25, sir. We have got 35 minutes more.
Okay. So this time.
সোয়াগারটা পর্যন্ত যেতে পারবো স্যার।
Hafiz bhai.
Jamil, comment on this?
Again, sir, it's paced.
Yeah.
So this is great. I mean, I'm glad that everybody, majority of got it. What percent people answering these questions?
Sorry, sir. I didn't notice the total number, but
again, I would like to encourage the audience, please do answer. I mean, First of all, we can answer in two different ways. We can answer by thinking about something. We can also, sometimes we do random choice. Even if you do random choice without thinking, then you commit yourself, and then when we discuss the answer, that will become a learning process. So please do answer.
Bidur, let me relaunch the program. Don't do it yourself. I can do it.
Again, I have expanded the ECG. You can see lead V1.
Yes.
You can see the spike. This is a little bit better than the other one. And once we have pacing complex, we should not comment on left atrial enlargement or not, because that becomes kind of mute because we don't know where the lead is. So this is the atrial paced rhythm. I think today I have just.
Vik bhai, আমার কাছে কয়েকটা ক্লিনিক্যাল কেস আছে, আমি আগামী সপ্তাহে করতে পারবো না, দেবো আমি?
Let me go, and so I'll skip through this ECGs. I'll do one more, and then you do this. I'll do two. So this one.
নটার দিকে আসতে বলো।
Shaila, yourself. Shaila. So, sir, 21 out of 76 attendees voted. 48% says it's B, atrial sense ventricular pace.
Okay. Any comment?
It is a fourth. Heavy sequential pace theorem.
No,
Wadud
is present, I think, because look at the rhythm strip, because the PR interval is variable in the rhythm strip. The first 3 beats is longer and gradually it is becoming shortened, and then it becomes fixed. So it's every sequential pace rhythm with every search hysteresis. I think it's there.
So sinus rhythm with first degree ABL is out because I can see pacing spike in the ventricle clearly. Atrial sense ventricular pace rhythm is not true because there is a pacing spike before the P wave. So basically, it's a choice between every sequential pace rhythm with hysteresis, every sequential pace rhythm. Both are correct, but I think more correct is such hysteresis because if you see the PR interval is long,
right, sir.
And suddenly if you look at it, you may think this pacemaker is malfunctioning. What this pacemaker is doing, I'm going to show you something. The same patient, what I did, I got the intracardiac from the pacemaker. If you see this, it keeps prolonging the interval to see if there is intrinsic conduction. And after a certain bit, it goes back to the short AV delay. And then it keeps doing it again and again. The purpose is to save battery life and allow AV conduction. But this feature should not be turned on if patient is pacing all the time. It is only good for patients who have first degree AV block with a pacemaker. One more and I'm done here. This. Please carefully look at the rhythm strip in the bottom. And what you are looking for the audience is it pacing in the atrium? Is it pacing in the ventricle? Is it capturing the atrium? Is it capturing the ventricle? Is it sensing intrinsic P wave or it is not? And that's what we're looking for.
I'm looking at your answers, Profik Bhai. 1, 2, 3, 4. Look at V5 and then answer.
No. Come, Hafiz, let the audience answer and then you will.
C.
So the audience polled for C, sir, 54%. Maybe sequential pace rhythm, failure of atrial pacing and sensing.
Okay, Hafiz, now your comment.
So now that's a tough one because the way you phrased it is that failure of atrial pacing and sensing, but we are seeing that there is atrial pace, ventricular pace, atrial pace, ventricular pace, atrial sense, ventricular pace, but this is little odd. And then ventricular pace, atrial activity, and then without pace, and then so it makes sense that this is probably both sensing and pacing failure of the atrial lead.
So this is what I have done.
Sir, আমি একটু করব?
Yes, follow.
In the rhythm strip, what we find, the initially both atrial ventricular pacing. Now, look at the fourth one. There is intrinsic QRS complex coming on when the ventricular pacing just started. And thereafter, the ventricular pacing is not there, but the atrial spike is there. And it's not actually sensing the atrial beat that's already present. It's sensing the ventricular beat. It's not producing any ventricular pacing, but it's not sensing the atrial pacing. And occasionally sensing one beat in there in the later part, the fourth from the last, it seems that there is no pacing at all. But there is somewhat failure of the atrial sensing and pacing, but ventricular sensing is quite all right.
What I liked about the answer Rafiq bhai gave, answer sheet, because that there is no comment about the ventricular lead. That could have been problematic.
Okay.
And the spacing spikes are in the PR segment in the middle complexes.
Yes. So what I have done, this star, I have expanded it. You see that there is a pacing spike. There is no corresponding P wave. Like here, it is intermittently failing to capture. No, nothing here. Over here it captured actually, and the ventricle captured. And then I have highlighted this. There is a P wave, but still there is a pacing complex, a pacing spike. And again, there is a one. This one can say, well, it is too close, but this one, there should have been no pacing in the atrium because it should have sensed this. It is a failure of atrial pacing and atrial sensing. Ventricular, I cannot make any comment. Ventricle is capturing this beat. Now, fourth beat is a pseudo fusion. And there is another part for our senior physicians here. There are two pacing spike. And I think one is atrium and one is ventricle.
Yes,
yeah.
Why, Tushar? I would like this question for Tushar. Why is there a second spike here? Any comment? And why is this such short interval? Well, this is what happened.
Short PPM.
As this is not sensing the atrium, it is pacing the atrium. And there is a feature built in the pacemaker that if after atrial pacing, there is any sensed ventricular event, it will pace the ventricle at a short interval of 110 milliseconds, which is called safety window pacing or 110 phenomena. Now, this phenomena was very, very important in the days when we had unipolar pacing. What would happen? That somebody with complete heart block has the atrial pacing, and atrial pacing spike is seen by the ventricle, and it stopped pacing the ventricle. And it happened quite frequently, and they introduced this feature called safety window pacing. So this is not a malfunction. This is a normal function. Please remember this. Thank you. And Hafiz, please take over.
It's nice.
Can you see my slide?
Yeah, please.
Yes.
Please do slideshow, Hafiz.
Yes.
So this is actually the collection from this week. This was one of our fellow did these cases. 57-year-old coming with chest pain, and I let you read the whole thing about the chest pain. Pleuritic positional myalgias, patient with hypertension, hyperlipidemia. And this is the initial EKG. So keep that in mind. This is the initial EKG, okay? And this is the laboratory data. White cell count high, creatinine normal, troponin 76. I don't know what generation of troponin you are doing, but we are doing 5th generation, and now it is in 76,000 per liter. So 76 basically. And then BNP and normal, and then procalcitonin, CRP, and then chest X-ray. In the COVID time, I don't know why we are so obsessed about procalcitonin, but in any case, it was normal. CTA negative for dissection PE, started on aspirin, heparin, and then this is the subsequent EKG. So keep that in mind because there will be some questions after this. So this is the subsequent EKG, and then this is further EKG. So look at this one, and then look at this change. So whatever you are thinking, keep that in your mind. This is the echocardiogram.
Hafiz, your slide is not moving. This is, no. Hafiz, we did not see the second ECG much.
Okay, all right. You can see the EKG now?
Yes.
Okay. I am giving you the history, the way the case evolved. So I'm not playing trick, giving you all the information. Can I move, Rafiq bhai?
Yes, I think we saw it.
Okay. Echo, this is the echocardiogram done. I did not give all the views, but if you want to know more, I can give you more. This is the echo. It is playing, right? You can see it is playing, yeah?
Yeah.
Okay. So the next step in the management, you have seen this patient, clinical presentation, you have seen the EKG, you have seen the data, and you have seen the echo. The next step in the management is start aspirin and colchicine, start colchicine, cardiac catheterization, temporary pacemaker, ibuprofen and prednisone, vasodilator, non-stressor, pharmacological stress test, assess ischemia. We use the regadenoson, the adenosine agonist for vasodilation and cardiolite, systemic nuclear stress test. I mean, I call it vasodilator pharmacology test. So any vote on this?
Colchicine is getting chance more.
Please, can you go back on the ECGs again so that audience can see it? The first, second, third.
Okay, this is the last one.
No, this is echo. This is the last one. Yes. Go back, please, again.
This one?
Yeah, one before.
There's no one before. This
Yes,
one, right?
fine. Yes, yeah. This is the first one. Yes. Now the second one, please.
This is the second one.
Yes. And
this is the third one.
Third one, yes. All right.
Now I can move.
Yes.
I can show you the choices that I gave you because this was discussed in the weekend that I was off, and I came Monday, and then I took over. So there was confusion in the team, so I put all the confusion in a question format.
Why didn't you give the choice of cardiac catheterization with temporary pacemaker?
Well, Rafiq bhai, sometimes you help with the given the question answer, right? Sometimes you help, sometimes you hard. I'm actually helping you by not giving temporary pacemaker cardiac catheterization.
Arun Maski, can you make comment? Arun Maski.
Yeah, looks like to me this patient has pericarditis. The one.
Okay. And then you saw the last EKG with complete heart block, right?
Go back. I didn't ask ECG.
Okay, so
Third one.
Third one.
so this one, right? So there is AV dissociation.
The
and
one
the,
Okay.
That
and
this one.
This one.
Hafiz, actually, this ECG that you are showing right now, probably 2 to 1 heart block. And the one before, after that, is complete heart block.
That's it.
Yeah.
So it has
So-
progressed.
So, Rafiq bhai, just to let you know that this one, I did not make any comment because to me, it looked like sinus, but it is, but after looking at this EKG, I went back and I thought this probably 2 to 1, but
Yes.
our EP guys, they did not make any comment, but they all agreed that this is complete heart block with junctional escape narrow.
And that last one. Yes.
So Arun must continue. Arun must.
Yeah. So
now the question is, what do we do?
So based on this patient's history, possibly this patient has with the 2:1, it has progressed to complete heart block. And from the history, possibly this patient could be a case of myopericarditis. So we will require temporary pacemaker, and then we'll have to assess this patient.
So I don't know anyone has any comment. I actually met this patient in the cath lab because I told them in the morning the patient needs a cath, because my thinking was this: if it is a perimyocarditis, that giving bradycardia and complete heart block is actually very rare. Like you can think about Lyme myocarditis, or rarely you can see sarcoid type, but not like this. And if you look at the troponin and the slide about how troponin rise can differentiate things, at that level of troponin, it is almost impossible to see those kind of myocarditis. However, myocarditis can give you 70 troponin, but it is unlikely that this will give you this bradycardia and then troponin of 76. Then the other possibility is that post-MI myocarditis is possible, post-MI pericarditis, I mean, post-MI pericarditis. But in that case, you have to decide that this is the coronaries we need to look at. Now, to answer Rafiq Bhai's question, why not I put that? Huh?
Can I comment? So if you look at the first ECG, second ECG, there is first ECG even in lead 3, there was some ST elevation. And lead second ECG, there is ST elevation in, can you go to the second ECG?
Yeah.
Okay. There is ST elevation in lead
AVF.
2,
AV3.
slightly downsloping, but in lead 3 also in AVF. Very subtle, and there is a Q wave. So somebody developing, and this, even though your panelist didn't, your attendee didn't think, but I think that was 2:1, and then goes into complete heart block with narrow QRS. Lyme disease, one of the things about Lyme disease is not present in Bangladesh, but it's very common especially in Maryland, where I live. I don't know how common it is in Nevada, but it is very common. Lyme disease, most of the time, will develop complete heart block with wide QRS. And it
because QRS is narrow here. But Rafiq Bhai, my issue is that when I saw this EKG, look at the lead 3. I called it, this is like Wallen's equivalent, almost biphasic. And the troponin 76. This actually, I argued that this patient was actually a STEMI that they missed.
I think so.
People who were upset with me, I was yelling the fellow that why didn't you activate? But in any case, the story does not end here. So I took to the cath lab, of course. So, and no, I went with the guide actually, because I knew that there is trouble. But for the interventionalist, the left side was good. My question is, and this is going to be an emotional issue. Will you go with the groin and then put a temporary wire, or you go with the radial? I'm still on radial.
Is that 76 troponin normal or raised?
No, 76 high, very high.
Okay.
What's the upper limit?
So will you go with the temporary wire, or you will be okay without the temporary wire?
Yeah, Hafiz, it depends on how much gut you have and if you have used the bathroom beforehand or not.
Okay.
I mean, somebody with acute infra-MI, 100% occluded RCA, I mean, listen, if you have enough guts, sure. Only concern with the radial is that if you are, let's say in the old days femoral approach, you already have a site there. If you are in trouble, you can quickly put a venous line, right? But with the radial, I don't think you can put a line so quickly.
But Rafiq Bhai, the interventionalists here would know when we prepare for STEMI patients, Even if I'm going radial, as a rule, we prep the groin. So you need to go to the groin and temporary wear, we jump on the groin. It is ready.
Well, I'll tell you something, Hafiz. I mean, I get a lot of patients with complete heart block with white QRS, and I go ahead and put permanent pacemaker without any temporary.
Right. I have issues with that. I'll tell you.
No, I'll tell you. So, but that's the question is, have I run into trouble? Yes. Trouble means as soon as I put the lead in, patient went into complete heart block, asystole, and I used that lead as a temporary.
Yes.
But same in this scenario is a little bit different because it's the junctional escape rhythm. And so the AV node, so that puts it in a little bit more comfortable position without even a temporary.
Actually, I was thinking about this conference because I said it's a good case. When I was going to do this, I said, I'll show this case on Saturday, but let me do an experiment. I gave atropine before I put the wire down. What do you think about the atropine we'll use? Because if the atropine, let me see, what do you think? What do you expect? Atropine, I gave 0.5 and then 0.5, total 1 milligram.
No harm, actually.
No harm, very good. So no harm and no response. Otherwise.
Right, exactly.
So
I wouldn't give atropine because the place that atropine is going to work is already gone. And unless you fix the RCA, it's not going to come back.
Yeah, you are so right. I actually give atropine with the radial. If there is a sinus bradycardia, Wenke back, I usually preemptively now give atropine. In the past, we used to give atropine after. I give preempt so that I don't need temporary wear, although I have groin prep. For the interventionalists who are doing the STEMI, my advice is that don't be too brave. At least put a venous line for ready to put a temporary wear. You don't need to be too brave. But I did reckless anyway. And I gave dopamine after this. And after the dopamine, I said, if that increases the heart rate, then I'm not going to put a temporary wear. So I used dopamine, and then I put the wear, and no further bradycardia. Actually, with the dopamine, the sinus node came back. It was sinus stack, as you can see. And then the patient's EKG came like this.
I don't think it was the dopamine, it was the vessel opening up that did it.
Both ways, yes. I will not be able to. But now question is what you do now.
As far as the heart block is concerned?
Yeah.
Nothing.
So nothing. So the patient goes home. And then we prove.
Okay. I'll give you this scenario. Inferior myocardial infarction, if the AV node artery is involved, you can develop heart block. And that damage most of the time is not permanent. So once you have intervened and it has come back, even if it did not come back today, you'll wait at least 48 hours to see if it has come back. That is true for anterior myocardial infarction. If infarction conduction did not come back same day, it is unlikely to come back again.
Actually, anterior, Rafiq bhai, in our guidelines and with complete heart block, will be like, I should not say this, someone will be stupid not to put a temporary wear.
Exactly.
Because you are that you can't rely. Only tried this because the junctional escape was narrow, and I thought that let's take a chance. But you need to be careful about ready to roll with the temporary wear, and then post revascularization, you need to observe the patient and then not to just send hours after the intervention, just wait, watch 36, 48 hours and then send home. Let me do a quick patient because this is very interesting one. 34-year-old found confused and admitted with vomiting. There was a suspicion for, Boerhave's esophageal rupture, but that was not the case. Patient was found to be diabetic, has history of substance abuse, and this is the EKG. This is the EKG. comment from anyone?
Sinus
Only
rhythm,
Bhumi-
non-specific changes.
Yes, and then look at the QT. QT is very prolonged. Patient was diagnosed to have hyperosmolar diabetic state, and then this is the blood count, glucose 1350, magnesium was low, and then the UDS, urine toxic screen was methamphetamine. And patient was shown to have sinus bradycardia overnight, and this was telescript.
Ah. A long QT. And it, do you have a longer ECG? We want to see whether it's a torsa.
You can see the twist, Wadud. There is a twist.
Yeah, but a longer ECG would have been shown it beautifully.
Okay, so now what do you do?
Can you show again the clinical scenario, please?
Calcium and magnesium, that's important.
In the clinical scenario?
Yeah.
So, confused, and then vomiting, then diagnosis of hyperosmolar diabetic state. This is the blood magnesium, potassium 3.1, kidney normal, sinus bradycardia, but I don't have that rhythm, and then this.
Potassium, magnesium
So
replacement.
number one, Hafiz bhai.
Yeah.
Number A.
Yeah. So even the magnesium level low or normal, some will give the magnesium first. This is a very common board question in internal medicine that give ICD, which is wrong, and there is no need for cardiac cath or anything. So, and then avoid all these.
Yes.
And then I will finish with the last case. 80-year.
Can I make a comment?
Yeah.
All of us should be careful about diabetic ketoacidosis and other things, because whenever we are actually controlling the blood sugar, our potassium level will dramatically fall down and the patient may have arrhythmias. We should all pay attention to that.
And by the way, I just wanted to tell you that sometimes it happened to us. They use the loperamide and then QT prolongation, and then they use this for detention of the substance abuse. And in this case, potassium, magnesium correction may not work. And sometimes you need a temporary wear pacemaker to overdrive pace to get out of these episodes of polymorphic VT. So this is a patient from Kansas, and then came into us AFib, and then this is a pharmacology issue. Patient was on coumadin, sotalol, hydralazine, losartan, and then this EKG.
Lead 3 to seem to show there is some.
Yeah, actually lead 2 shows the best, because what happened, these patients had sotalol.
Yeah.
Look at 80-year-old, it is renally cleared, renal function deteriorated, and then you develop this long QT. And also looks like there is a 2-to-1 block.
Hafiz, can I comment on this?
Yes.
Okay. So this basically, if you look at the first 2 beats, sinus rhythm, PR interval about 220 millisecond, QRS normal, QT actually is not prolonged. It's about 480 millisecond. Okay, so what's happening in this? This is a classic case where a patient will end up getting a pacemaker when they don't need it. Because what's happening? Look at the first T wave, rounded. Second T wave is a pointed. That means there is a premature beat. So it's a classic example of sinus rhythm with supraventricular premature beat in a pattern of bigeminy which is not conducted. And physicians keep sending me these patients to put a pacemaker in. I keep refusing putting pacemaker in these patients.
And in this case, there was an offending agent, and we just need to sit tight. And then this happened before discharge.
I am not so sure that the sotalol was the culprit in this case.
Yeah, definitely, Rafiq bhai. Sotalol is notorious for its metabolism and then got accumulated because of the worsening renal failure.
But
the elderly lady with renal clearance problem, only thing we did is stop the sotalol and then EKG returned to like this.
Okay, this is what I will recommend. This patient, if you do 30-day heart monitor, you will see again multiple places. She will have non-conducted P waves. So stopping sotalol was a good idea because with the renal impairment, it's almost impossible, especially in older patients, to maintain. I mean, sometimes I will give sotalol in renal failure patient once a day or once every 48 hours, 72 hours. That's very cumbersome to do. But those non-conducted P waves are probably,
So this patient did go with a telemonitoring 30-day, and then we'll follow up in the office. If I could not convince you with this one, let me show you this one, then quick one. 90-year-old. It came in 90-year-old, and then look at this. Patient is on Aliquis, amlodipine, synthroid, and diltiazem, and then had this. Okay, so this was in another hospital. Right bundle, left axis, AFib, and then they evaluated. We got the record, and there's nothing much there. So then the cardio, this was the TE at the time, and then after this cardioversion, patient was following up with the cardiologist. And we don't know because 90-year-old, she doesn't know what she's taking. And she came with this.
Hafiz, what is Eliquis?
Okay, sorry, Apixaban.
Yeah. What medicine she was taking?
So we found up with the medications. Patient was taking amiodarone, digoxin, and or metoprolol.
Anyway, I have to say goodbye. I have, if you don't mind.
Okay.
This time I agree with you. This time I will agree with you, whatever you decide. See you next week.
Well, my problem is that I have to follow up the patient. So and the safety issue. Last patient, we did not put any temporary wire or anything. Our pacemaker. We'll be following up in the office. What about this one, Wadud?
Have you discontinued the drug and putting a temporary?
The patient came in with bradycardia. This was the admission EKG.
Yeah.
We stopped everything. And now this is like 10 o'clock. And unfortunately, I was called in for another patient with cardiogenic shock and missed anterior wall STEMI. So I was putting a balloon pump and all that. I told my ex-fellow, now my partner, to deal with. And he could not get hold of me. So she was wondering what to do. And therefore, I'm giving you the choices. Because she said, yeah.
No, actually, as per the guideline, whether the patient was taking the rate-lowering drug like the digoxin, then
All are stopped now.
All are stopped. How much the drugs are essential? If there is no alternative, then we have to think for the permanent pacemaker. Whether the drugs are essential, can you stop this drug permanently?
Atahar bhai, I totally agree with you, but my question is, what you do tonight? Because this is
temporary.
Okay.
There is
Remember, last time we did not give temporary. What I'm bringing this issue up for the junior doctors, that in the last case we did not put temporary, but in this case, as Atahar bhai is rightly suggesting, that this is a temporary. But both occasions, patient has blood pressure, good blood pressure. Patient is still maintaining. But why we would be putting a temporary wire in this one? We did not temporary wire in last one. What will be the points in favor and points against?
This patient has right bundle branch block with the left anterior hemi block. She is very likely to, and also now has developed a very slow rhythm. So this patient is at risk for developing asystole or complete heart block and persistent very low ventricular rate.
This patient, is unreliable.
Right, exactly.
Block is probably infrahysian unreliable.
Right, exactly.
So we cannot take a chance. If this patient goes into trouble, then we'll be liable. So Rafiq bhai is not here. I was going to ask Rafiq bhai that, will you put a permanent pacemaker or will you do a temporary wire? I would do a temporary wire. Let's see that the blocks go away. But here is the thing. The EP guys will argue that there is significant conduction disease anyway. And this thing will come up, that if we have a problem with the rhythm control or rate control, can we give the drug later on? So that will be something, I will ask Atahar bhai to make a comment.
Now, initially I will put the temporary pacemaker first, then I will reevaluate. I will think about the drugs, that is amiodarone, digoxin, beta blocker. How much these drugs are essential? If there is an alternative choice for these drugs, then permanent pacemaker is, as per the guidelines, it is required. Permanent pacemaker. But if there is if you can stop this drug permanently, as per the clinical scenario, then we can avoid the permanent pacemaker. But if these drugs are essential, like the digoxin and like this, then permanent pacemaker is a choice.
So,
Hafiz bhai, why was she given apixaban?
No, the atrial fibrillation.
And then we have to give beta blocker in future. So I think she requires a permanent.
Remember, this was his initial EKG in another hospital with the AFib right bundle left axis. So she has bifascicular block from before. Now with the medications gotten worse. So I do not know what we'll do yet, because we just kept temporary wire. Yesterday, our EP guys said no pacemaker. He's rounding today, so they changed their mind. So I hope that they put a permanent pacemaker. I told them, no way you can get away with the permanent pacemaker with this. Echo is normal, LV function. So I have that all right.
Thank you, sir.
Mohsin, do you want to make
I have one question? How often you use amiodarone, metoprolol, and digoxin in one patient?
I almost never use. This is, to me, I think there is and I'm sure that with all due respect, whoever was treating in the other hospital, they probably did not want that way, because 3 AV blocking agent is going to be disaster, particularly a 90-year-old. But the patient has memory deficit and did not remember what medications to take and what not to take. So they changed so much that there was a problem with the patient's understanding of the medication.
Thank you, Hafiz bhai. 9 beautiful cases. Firoz, তুমি এখন এটা দেখাও, ECG of the week.
Thank you. Because
আমার মনে হয় Firoz, Wadud bhai, actually ECG of the week, actually the ECG was presented by posted by Dr. Sadi, but he is not here in the screen.
Tell it. We should wait for him.
I think we should not discuss the ECG today. Firoz, he is absent.
We can discuss it on the next day.
Yeah, we can do that.
Sorry, I took longer probably today.
Oh, very good, Hafiz bhai. Thank you.
Thank you very much. I think we are almost at the end of our session. Atahar sir, your final comments.
So it was a very nice session today. We have got the good number of the pediatric cardiologist and Dr. Jamil. Again, thank you very much for your nice presentation.
You're welcome.
You have stimulated us and stimulated the pediatric cardiologist. And again, we are having the another pediatric ECG session on the next day. Dear participants, the next Saturday, the presenter will be Dr. Rezona Arima and Naharuma. And Dr. Jamil, you will fight on that day. I think we will. And again, Dr. Chowdhury Hafiz, we are very much glad to have your ECG. Very nice presentation today. Excellent, excellent ECG. And we want to see like these ECGs again and again. Chowdhury Hafiz, thank you very much for your excellent participation. And we can see Dr. Mahabur Rahman. Dr. Mahabur Rahman Babu. We did not see you for the last few
minutes. Thank you, sir.
No. Actually, we did not see you last few sessions, but today we are very much happy to see you, Dr. Babu. Do you want to comment?
Sir, I was late today. I missed almost today also, but I don't want to miss this session. Thank you, sir. All are nice. Thank you, sir.
Babu, don't miss on next Saturday.
Yes. As a possibly there is also
Inshallah.
Swami Paudel. We want to thank you. And finally, thanks all the participants and for today's excellent session. And Abdul Wadud Chowdhury, Mohsin Hussain, Urmila, and Monish from the Nepal. Thank everybody.
And Arun Maski.
Hey, Arun Maski, yes. Arun Maski is always there. Arun Maski, you please keep some of the ECGs every day. No problem. If there is any time, we can see your ECG. Your presentation is always excellent. We enjoy your presentation. So, Firoz, you can conclude the session.
Thank you. Thank you all of you. And we are at the end of session. It's 11:10. We'll wait for another 7 days. Next Saturday, we'll look for some ECG changes in different pathological conditions. Dr. Naharuma and Dr. Rezwana are going to present the ECGs. And till then, night.
Goodbye. And stay safe.
Beximco and Saira Hussain, thank you very much. Saira, তুমি হচ্ছে যে ইনভাইট করো। আচ্ছা তুমি হচ্ছে যে রেজওয়ানা রিমা এবং নাহারুমাকে ইনভাইটেশন লেটার পাঠাও ফর দ্য নেক্সট স্যাটারডে।
ওকে স্যার, ওকে ঠিক আছে স্যার।
Okay.